Rheumatic heart disease, pathophysiology, clinical management. Rheumatic heart disease represents a serious cardiac complication of acute rheumatic fever, an inflammatory condition triggered by streptococcal infection. Understanding rheumatic heart disease and management and its origins is essential for preventing long-term complications. Represents one of the most significant sequelae of acute rheumatic fever, a systemic inflammatory condition with potentially devastating cardiovascular consequences. This condition emerges as a late complication of inadequately treated or untreated streptococcal pharyngeal infections, typically manifesting weeks after the initial bacterial infection has resolved. The disease affects millions of individuals worldwide, with particularly high prevalence in developing nations where access to antibiotics and healthcare infrastructure remains limited. Understanding the mechanistic link between streptococcal infection and subsequent cardiac damage is fundamental to appreciating cardiac prompt diagnosis and treatment of throat pathophysiological remains a cornerstone of preventive medicine. Colonization of the pharynx, which triggers an immune response designed to eliminate the bacterial pathogen. However, the antigenic structure of group A streptococci shares molecular similarities with components of cardiac tissue, particularly the myosin heavy chain and tropomyosin found in heart muscle and valve structures. This molecular mimicry creates a scenario where antibodies and T cells generated against streptococcal epitopes cross-react with cardiac self-antigens, initiating an autoimmune attack on heart tissue. The resulting inflammation can involve multiple cardiac structures, clinical manifestations including the myocardium, rheumatic fever, pericardium, and endocardium. Rheumatic fever typically presents 2 to 4 weeks the valve after apparatus, streptococcal being particularly vulnerable, though some patients may not recall an antecedent infection. The clinical presentation is characteristically multisystemic, reflecting the widespread inflammatory nature of the disease. Patients frequently experience fever, though the temperature pattern may be variable. Polyarthritis affecting multiple joints represents another hallmark feature, causing significant pain and temporary disability, though notably without causing permanent joint damage. Neurological manifestations may include chorea, an involuntary movement disorder characterized by jerky, purposeless movements that can severely impact daily functioning. A distinctive skin manifestation known as erythema marginatum may appear, presenting as non-pruritic, evanescent lesions with characteristic pale centers and erythematous borders that appear and disappear over hours. Key points: fever occurring in approximately 90% of acute presentations. Cardiac involvement, polyarthritis involving knees, ankles, hips, approximately and shoulders half of all patients for rapid migration. Acute rheumatic fever develop or involuntary movements ranging from subclinical and fine motor control, detectable only on specialized imaging to overt carditis with hemodynamic consequences, raised erythematous margins. Acute carditis during the initial episode may present with pericarditis causing chest pain and pericardial friction rubs, myocarditis affecting cardiac contractility, or endocarditis causing acute valvulitis with new or changing heart murmurs. The inflammatory process during acute episodes may be reversible, but repeated attacks or severe initial inflammation can result in permanent structural damage to the valve apparatus. The mitral valve bears the brunt of this damage in the majority of cases, though the aortic valve may be involved either as a primary target or in combination with mitral disease. Less evolution from acute inflammation pulmonary to chronic valve may be affected. Typically, the transformation from acute carditis to chronic rheumatic heart disease occurs through a process of progressive valve remodeling and fibrosis. During the acute inflammatory phase, valvular edema and inflammation cause functional disturbance, but with appropriate rest and anti-inflammatory therapy, much of this acute swelling may resolve. However, repeated episodes of acute rheumatic fever promote progressive fibrosis, calcification, and structural deformity of valve leaflets. The mitral valve commonly develops stenosis, where calcification and commissural fusion reduce the valve orifice area, impeding blood flow from the left atrium to the left ventricle during diastole. Alternatively, or concurrently, valvular regurgitation may develop when inflammatory scarring prevents complete cooptation of valve leaflets. Some patients develop mixed stenotic and regurgitant lesions, complicating hemodynamic management. Long-term cardiovascular aortic valve disease typically manifests chronic as rheumatic heart disease, where scarring and multiple serious cardiovascular complications during diastole over years, allowing backward flow of blood into the left ventricle. Progressive valve obstruction or regurgitation imposes increasing hemodynamic burden on the heart, eventually leading to ventricular dysfunction and congestive heart failure. The distorted geometry of damaged valves and chamber dilatation promotes abnormal electrical conduction, predisposing patients to atrial fibrillation, a complication present in approximately 40 to 60% of patients with significant mitral stenosis. Atrial fibrillation introduces additional risks, including stroke from thromboembolus originating in the fibrillating atrium, necessitating anticoagulation. Rheumatic valve disease also creates a substrate for infective endocarditis, pathogenic organisms, clinical evaluation, abnormal valve tissue, diagnosis and of rheumatic heart disease requires integration of clinical valve disease, physical examination findings, and arrhythmias and multimodal imaging of contractile dysfunction, the ultimately resulting in symptomatic temporal relationship in many patients if untreated streptococcal infection or acute rheumatic fever episode, though this may not always be clearly documented. Physical examination may reveal findings consistent with active carditis or evidence of chronic valve disease, including specific heart murmurs characteristic of mitral stenosis, mitral regurgitation, aortic stenosis, or aortic regurgitation. Echocardiography serves as the cornerstone diagnostic modality, providing detailed anatomic information about valve structure, leaflet mobility, orifice area, and quantitation of stenosis severity and regurgitation magnitude. Transthoracic echocardiography suffices for most evaluations. Medical management strategies. Echocardiography may enhance visualization of rheumatic heart disease focuses on symptom relief, planning, prevention of complications, additional investigations, and prevention of including electrocardiography may document evidence of fibrillation or recent rheumatic fever require anti-inflammatory therapy can reveal cardiomegaly or pulmonary edema with the intensity of therapy depending on disease severity and cardiac involvement. Long-term penicillin prophylaxis represents a critical intervention, with regular intramuscular penicillin G injections or oral penicillin administration preventing recurrent streptococcal infections that would trigger additional inflammatory episodes. The duration of prophylaxis depends on factors including the presence of carditis and whether residual cardiac disease persists, with some guidelines recommending lifelong prophylaxis for patients with established rheumatic heart disease. Diuretics manage fluid retention and congestion when heart failure develops. Rate control with beta blockers or calcium channel blockers becomes necessary and interventional fibrillation emerges, while anticoagulation becomes necessary when medical therapy can no longer maintain adequate hemodynamics or when including angiotensin-converting enzyme inhibitors may improve hemodynamics. Mitral and reduce ventricular obstruction may be amenable to mitral commissurotomy, a procedure that separates fused valve commissures to enlarge the orifice area, potentially deferring or avoiding valve replacement. Alternatively, catheter-based balloon mitral valvotomy offers a less invasive approach in selected patients with suitable valve anatomy. Valve replacement represents the definitive solution when structural damage prevents adequate valve function or when stenosis recurs after prior commissurotomy. The choice between mechanical and bioprosthetic valve replacement involves careful consideration of patient age, lifestyle, bleeding risk, and long-term anticoagulation requirements. Mechanical valves require indefinite anticoagulation but offer superior durability, while bioprosthetic valves eliminate anticoagulation given the potentially devastating consequences of rheumatic heart disease. Eventual re-replacement. Prevention represents the most effective and economical approach, and perioperative care primary prevention involves prompt diagnosis, though valve replacement treatment carries inherent risks and lifelong follow-up antibiotic therapy, typically a 10-day course of penicillin, which substantially reduces the risk of acute rheumatic fever development. Public health initiatives promoting access to antibiotics and diagnostic testing in resource-limited settings have shown remarkable success in reducing rheumatic fever incidence. Secondary prevention through long-term antibiotic prophylaxis prevents recurrent streptococcal infections in those with established history of acute rheumatic fever or rheumatic heart disease. Tertiary prevention focuses on managing established rheumatic heart disease through optimal medical therapy and timely surgical intervention to prevent complications and optimize long-term outcomes. Rheumatic heart disease remains a substantial global targeting patient awareness, particularly in low and middle-income antibiotic where streptococcal and maintaining prophylaxis elevated and healthcare access remains limited. Millions of individuals carry the burden of chronic rheumatic heart disease, with substantial morbidity from heart failure, arrhythmias, and stroke. The WHO and international cardiovascular societies recognize the need for strengthened disease surveillance, improved access to diagnostics and treatment, and sustained public health initiatives to reduce disease incidence. Emerging evidence regarding novel immunotherapies and improved surgical techniques continues to evolve, offering promise for enhanced outcomes in affected populations. Continued investment in global health initiatives targeting streptococcal infection control and expansion of cardiac care capacity in resource-limited regions represents essential steps toward reducing the global burden of this preventable medical content.